Hello friends, I am Dr. Sourabh Patwardhan from Nandadeep Eye Hospital, PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. In this video, I'll be showing a case of mature white cataract, a 60-year-old male, and there will be few things which I would like to share, so just watch. Now I am using a 23 gauge MVR here. Usually for intumescent cataract I try to use a smaller MVR so I can keep the anterior chamber more I would say tight so that there is no visco leakage. And then 2.8 incision here. The patient is not fixing the eye, so I tried to support the globe with the limbs there, and then I made the 2.8 incision. I usually make a uniplanar incision in these cases. Now here I take a tuberculin syringe, withdraw some dye and then withdraw some air. So when I inject, first the air comes, and then if you notice I just put the dye drop by drop on the anterior capsule. What this does is that there is no jet of this dye across the zonule. So in some cases where there is a zonular dehiscence or zonular weakness, the dye might get injected into the vitreous cavity. So it's a good habit to just drop it put it drop by drop over the anterior capsule. And if you notice, I used the heavy dispersive agent here, and the moment I injected the visco, the anterior capsule actually became flat. Now you can see when I touch the anterior capsule with my forceps, it's actually flat. So that is a sign that it's not an intumescent cataract. So I can just go around and do a regular capsulorhexis without any risk of extension unless I do some wrong maneuvers here. So I'm using the Haldipurkar forceps here, and use of the Hylucoat, which is a combination of chondroitin and hyaluronate, makes the rhexis very easy. And because of its flatness, now you can see the capsulorhexis is very well controlled. Now I am going to use the Centurion phaco system here, and I'll be using 36 IOP throughout, and sometimes I will increase it to 46. So generally it helps in lower IOP phaco, more comfortable for the patient. And just I want to show this particular part again, because many times people struggle in that small incision, but I can negotiate. You can see my longer Sinski, which is 1.5 millimeter. Once the tip has to go parallel inside through this incision, so it avoids any tear or damage to this side port incision. So that is something to learn whenever you are using these longer instruments through the smaller side incisions. Now this is my usual technique in these cases. I do deep trench near the center. I just cross the center with this deep trench, and then I will just bury using the chop setting, which are the longitudinal phaco settings, and then I chop the nucleus into two halves. Now I want to highlight here the position of this long Sinski, 1.5 millimeter long, which I call Patwardhan chopper. It's a hybrid chopper because we can do horizontal chop as well as vertical chop with this. Watch the position of that tip. It is exactly in front of the phaco tip, and that's what is essential if you want to do a good chop. Apart from that, you also need a good hold over this nucleus. So I want you to listen to the sounds which are there. So as the vacuum increases, you can listen to the pitch of the sound increases, and that's very important. You have to keep listening to the sound. Whenever the pitch goes down, that means your tip is not occluded, vacuum is not built up. So you have to bury again into the substance of the nucleus so that the vacuum again increases, so you have got a good hold over this piece. Now as you know that this is not a very I would say hard or leathery kind of cataract. It's more brittle, though it is dense. Now listen to the sound and listen to the pitch, and where I want to bury it more to get better hold, and I want the pitch to increase, indicating that the vacuum is high. So when the vacuum is low, vacuum built is low in the peristaltic machines, You have to make sure that tip goes further inside the matter and holds the nucleus well, else you will not get a good separation. The hold over the nucleus pieces is the essential part while doing the chop. Apart from that, I showed the position of the Sinsky there, or the chopper there is another important thing. Now while quadrant removal, just watch the tip of my phaco, and you will find that it always stays around that Purkinje image, which is the basically the central part of the anterior chamber, which is the safe zone. So you avoid taking that tip away from that Purkinje image as far as possible during the procedure. So watch the posterior capsular movement very carefully, watch for any anterior chamber fluctuation, and adjust the fluidics accordingly. I think the best part of any machine is the best fluidics, and best fluidics take care of the complications. Thank you.